Hey everyone, so today we are going to talk about a very broad category of drugs, and those are drugs that work in the respiratory system. So first we've got to define what is exactly the respiratory system and how does it work? We all know that we breathe, we need air to survive, but what's exactly going on when we take that deep breath? Well, the respiratory system is responsible for exchanging oxygen from the air with carbon dioxide from the body. So carbon dioxide is the body's waste product, and we take in oxygen in order for our cells in our body to respirate, to breathe. The cells of the body require oxygen for energy, and then they produce carbon dioxide as a waste product. Now, the diaphragm, which is the muscle at the bottom of your lungs, that expands and contracts in order to facilitate breathing, otherwise known medically as respiration. Now, air is carried from the trachea, the windpipe, down into the lungs, and the trachea keeps branching out into these smaller and smaller little tubes. So you have one trachea that goes into two bronchi, or airway branches, that lead into each lung. You have your right lung and your left lung. These bronchi then branch into smaller bronchial tubes, and then to even smaller air sacs known as alveoli. Now, it might sound like a pasta, especially if you're Italian like me, but this is what alveoli looks like. And as you can see, the alveoli of the lungs facilitate gas exchange, where the oxygen and carbon dioxide are exchanged into the blood. So we take this deoxygenated blood that comes in from the veins, right? And it comes in from the pulmonary artery, but regardless, you take deoxygenated blood into the lungs, the CO2, that carbon dioxide, gets swapped out, and then it gets exchanged for that oxygen, which is directly coming through that alveoli. It diffuses through that very, very thin little membrane that the alveoli have as part of the cells, and it diffuses out into the bloodstream, and then that oxygenated blood gets pumped by the heart throughout the entire body to oxygenate everyone. So the respiratory disorders occur when gas exchange or breathing patterns are interrupted or obstructed in some way. So something is causing those alveoli to not be able to do their job properly. And this is just a quick little overview of the entire respiratory system. So yes, it includes the nasal cavity as well. You can breathe through your nose as well as your mouth. And as you can see, there's the trachea or windpipe, and that splits into two, becomes the bronchi. One bronchi is in singular is known as one bronchus. And as we get farther and farther into the lung, you can see that bronchus splits almost like a tree or like a cauliflower. It's a fractal where it just keeps getting smaller and smaller and smaller to extend that surface area within the lungs, so we can get all that air and all of that good CO2 to oxygen exchange. And of course, the alveoli, which they kind of look like little grapes or like grapes on a vine, they're surrounded by capillaries, which in turn bring that deoxygenated blood and make it oxygenated by exchanging gas through that very, very thin alveolar membrane. Now, we have a ton of common respiratory disorders. I will preface this by saying at the time I'm making this video, it is November 2021. So yes, we know about COVID, but if this video is used at some point in the future, I'm not covering it for this specific video on respiratory disorders. That is to say, COVID-19 and the therapeutics are not entirely known quite yet. We're just starting to be at the advent of oral therapeutics for COVID, so I'm not going to cover any COVID drugs at this time, just supportive therapies. That being said, let's start with something we do know quite a lot about, and that is asthma. And asthma is probably one of the most common respiratory disorders that you're going to run into, especially in an outpatient pharmacy setting. Asthma is simply chronic airway inflammation related to stimuli or hyperresponsiveness and airflow obstruction. So what does that mean? It means that you have chronic inflammation of the airway, which makes it harder to breathe because that air cannot get through as an unimpeded force through the bronchioles, through the trachea, through the alveoli. Symptoms of asthma include wheezing, acute bronchospasms or airway contraction. So the airway contracts up because, especially with allergic asthma, for instance, it senses a foreign invader. And because it senses something foreign, it wants to protect the lungs from inhaling whatever it deems to be a threat. So sometimes the immune system or immune-related asthma will actually trigger those acute bronchospasms or airway contractions, even when it's not warranted. And of course, with asthma, as with most respiratory disorders, people experience breathlessness. Now, in a similar vein, we can have allergic asthma. We could also have immunomodulated asthma and some other varieties of the disorder. Sometimes we just have straight up allergies, and these would be allergic response to food, drugs, animals, insect bites, dust, mold, you name it. People can be allergic to just about everything. Now, that causes a potentially life-threatening airway closure treated with epinephrine. So anaphylaxis is a potentially life-threatening airway closure, and that's when you need an EpiPen, that epinephrine pen. Maybe if I can talk tonight, we'll get it out eventually. We also have bronchitis, which is an infection producing excess mucus in the bronchial tree that makes breathing difficult. Most people experience bronchitis at least once in their lives. And this just goes to show the difference in a normal lung versus an asthmatic lung. So you'll see our bronchi stretching into the alveoli as they get thinner and thinner and thinner, with a smaller space for that air to effectively pass through. You can see the normal lining of the bronchi has a normal amount of mucus, which lubricates the airway and allows for that fluid to diffuse and for the air to diffuse as well into the lungs. And the muscle is quite relaxed, so the air has no problem flowing in and out of the lungs. However, in asthma, we have excess mucus and we have a swollen and irritated lining. And you can see right there, look at all the space we have for air on the normal lung, and the tiny, tiny space that these poor asthmatic patients have to try to breathe with when they're hardly at even maybe 50% or 30% of what they would normally be getting for lung capacity. And over on this side, pathology of asthma, you see that normal airway versus a wall that's inflamed or thickened, excess mucus that's been secreted, and tightened or smooth muscles. Now, chronic obstructive pulmonary disease is otherwise known as COPD, and it's another very, very common respiratory disorder, which is also often seen in hospitals if it gets bad enough. And COPD actually isn't one disease, it's a group of disorders. So that includes emphysema and chronic bronchitis. And both of those conditions make it significantly difficult for people to breathe. A lot of times, unfortunately, in end stage COPD, many people have to be put on oxygen, or you might see them carrying around an oxygen tank with them, supplemental therapy with that. It can be quite devastating. They might be bedridden or can't leave their house, can't perform activities of daily living. Now, COPD causes the destruction and chronic inflammation of the bronchioles, significantly lowering oxygen intake. So COPD progresses to the point where it's actually destroying your lungs. And the main cause or risk factor of COPD is smoking. So that's why we encourage people to quit smoking as much as we possibly can, because it leads to a whole bunch of not just respiratory problems down the road, but even cardiovascular and other health problems. Symptoms of COPD include a shortness of breath during everyday activities. Chronic cough and fatigue is also quite normal with COPD, as well as excessive mucus and sputum production. Blueness of lips or fingernails, otherwise known as cyanosis. You know the color cyan, that bluish color? Blueness of lips and fingernails indicates that not enough oxygen is being transported to the extremities of the body through the bloodstream. So that is indicative of a very serious breathing disorder if you start noticing that the lips and fingernails of people with COPD are blue. Now, COPD generally affects older people. If we were to talk about a disease that specifically affects usually younger people, it's croup. It's a viral respiratory infection, mostly affects children under 5 years of age. It's characterized by a very distinct barking cough that's caused by an inflammation of the larynx. It's a swelling of vocal cords. It can be quite serious, but we are able to pretty well treat it and support any young children or even babies who develop croup. And this just goes to show what a normal x-ray, you might have seen these if you're working in a hospital, go by the radiology department or what have you. You have your normal x-ray of a person with normal lungs. So you can see those normal lungs. There's the heart that's in front of the lungs. That's that little grayish thing right there. So your right lung, left lung, and there's the heart right in front of it. And you can see the rib cage surrounding those lungs. And what we like to see is a healthy amount of blackness. That blackness is just empty space within the lungs, which indicates air. Now, what happens in COPD, and the reason they can't breathe quite well, is their lungs are actually overinflated. Now, you might say, well, they have so much air in their lungs. Why are they short of breath? It's mainly because of this right here. This is the diaphragm. So at the bottom of this picture, you can see where I'm moving my mouse. This is the diaphragm muscle that pushes up and down in order to facilitate that breathing. So when you breathe in and out, your diaphragm expands and contracts. Now, when the lungs are overinflated, the diaphragm can't do its job as well. So it can't push air as effectively out of the lungs or contract and let air back into the lungs as well as it normally would to facilitate that gas exchange, because it simply has nowhere to go. And similarly, the heart is pushed to the side. So the heart, which should be right in the middle right here, well, not quite in the middle, but just offset to the side, is pushed all the way over here in this poor COPD patient. So you can see that large amount of black, that large amount of overinflation, the heart pushed to the side, which can cause any number of other problems, and that compression of the diaphragm, which leads to them having breathing problems. Moving on, we have pertussis, and if you're going to be around any young children, especially, or infants, make sure to get those Tdap or those DTaP vaccines, whichever you are indicated for. Pertussis is otherwise known as whooping cough. It's a bacterial infection, most common in young children and infants. It is entirely preventable to keep you from spreading whooping cough to others if you get vaccinated. It's also very highly contagious, and it can cause violent and rapid coughing and difficulty breathing. It's actually quite a serious infection for these poor little kids who contract it. And it's characterized by this very distinct whooping cough, which is why it gets its name. We also have pneumonia. And like I said, I'm not talking about COVID-19 related pneumonia, but you can develop pneumonia from COVID. Pneumonia in general is an infection of one or both lungs caused by a virus, bacteria, or fungi. So the virus can be anything like the flu-related pneumonia. It can be related to COVID. Bacteria, for instance, you might have a sinus infection or something that moves down into your lungs, and then you get an infection that way. Even fungi, especially in immunocompromised patients who might have immune systems that can't necessarily fight off fungi. I think of like cryptococcal pneumonia in patients with HIV and severely weakened immune systems. That's a typical fungal pneumonia infection. Now, pneumonia is essentially just the accumulation of fluid in the lungs, and it causes inadequate, or in some cases, a complete loss of air exchange at an alveolar level. So when there's so much fluid in the lungs, it gathers in those tiny little alveoli, those tiny little grape sacs, and because the fluid or the sputum, the mucus is so thick, none of that gas can be exchanged in the capillaries, and you're not getting enough oxygenation of the blood, and indeed not getting enough exhalation of the waste product carbon dioxide either. Now, symptoms of pneumonia might include a productive cough, which is green or yellow sputum if it's a bacterial infection. Generally, it's a bit clearer with viral infections, but not always. And a productive cough just means you're coughing up stuff. You're coughing up phlegm or what have you. Fever, sweating, and chills are also quite common with pneumonia. Shortness of breath, of course, and chest pain or wheezing, because you're coughing so much, you'll get pain in your chest, and wheezing because you're struggling to breathe. And this just goes to show, as we're becoming sort of armchair radiographers, normal lung with normal lung capacity, and that nice clear black air that you can see has in the top left-hand corner of this slide. And there you can see the heart right there. Now with bacterial pneumonia, you have a bunch of what you call infiltrates, these little filaments, these white filaments. So you can see there's not as much air in the lungs as there should be. There's an accumulation of mucus. Now in viral pneumonia, usually that mucus is not as visible, but you can still see it. You can still see those little filaments in viral pneumonia. And this is what makes COVID so nasty. You can see there's hardly any room for air left in these lungs. And there's a considerable amount of pooling of those mucus and secretions in the bottom of the lungs, which makes it very, very hard for COVID patients to get the air that they need. So if there's any excuse for getting vaccinated, just show her, if you're trying to convince someone even at this time, just show someone this slide, and you can say, hey, Which lungs would you rather have? Anyway, off of my high horse, off of my little soapbox there for a second. Let's treat respiratory diseases and disorders. Well, treatment of respiratory illness is based on both therapeutic and symptomatic treatment. So we treat for symptoms if we can't cure it outright, and we treat for long periods of time. So we want therapy as well as treating the symptoms. Many symptoms can be managed with pharmaceuticals, even if the disease itself cannot be cured. We can use antibiotics for bacterial infections. So bacterial pneumonia can be treated with antibiotics. Antihistamines, especially antihistamines for any sort of allergic reaction within the airway. Antitussives or cough suppressants can be quite useful, and many of them are over the counter, as well as decongestants. And in this lecture, we're going to be focusing on bronchodilators. Now, bronchodilators are medications which make breathing easier by widening the airway in the lungs. So we want to widen the airway to allow more air to flow in. What's the best way to administer a bronchodilator? Right into the lungs, of course. So that's why we want to deliver the drugs directly into the lungs with inhalers. Now, inhalers might be used for acute or chronic conditions. So a rescue inhaler restores normal breathing in the event of an asthma attack. So if you have an acute breathing emergency or a breathing problem that just came on, maybe it's exercise induced. A lot of people have exercise induced asthma. If they are playing sports and they're practicing or running around a track and they get suddenly quite out of breath because they might feel an asthma attack coming on, they can use their rescue inhaler. Similarly, they might use their inhaler before they exercise because they know they're going to need that extra bronchodilation and they want to be prepared for it. Now, a long-term inhaler is used to treat chronic respiratory conditions. So that is used to prevent an asthma attack or a similar exacerbation or of a breathing disorder like COPD. So you're going to take your chronic long-term inhaler every day, regardless of your breathing status. We always want to advise our patients, clean inhalers regularly. This was also highlighted in your pharmacy technician book. You want to clean those inhalers regularly. Why? Because you reuse them. So germs can build up and grow on the devices. And manufacturers provide specific instructions for cleaning with each inhaler. Generally, it involves rinsing the inhaler for about 30 seconds with warm water. And proper technique for inhalers is essential because almost every inhaler has different instructions. Now, unfortunately, I cannot play audio. I can hear the audio, but it's going to be muted for you guys. There's a wonderful House video, if you like the show House, called Inhaler Fail House MD. I highly recommend you check it out because you can never assume that you know how a patient is going to be using their inhaler. Anyway, bronchodilators. Medications that relieve bronchospasm are known as bronchodilators. You'll recall that bronchospasm is that narrowing of the bronchi, those breathing tubes, accompanied by wheezing and coughing. So bronchodilators work by increasing the opening of the bronchi, which allows for more airflow. Simple, right? Now, they might be used to treat acute or chronic respiratory conditions, depending on the type of inhaler and depending on the drug that's being used. So there's several categories of bronchodilators. We're going to go through them all. We have inhaled corticosteroids, long-acting beta agonists, short-acting beta agonists, anticholinergics, and leukotriene inhibitors. So let's get started. Inhaled corticosteroids work by decreasing airway inflammation and dilating the bronchi to improve airflow. So corticosteroids, think of your anti-inflammatory drugs. They're very, very useful in decreasing inflammation. Steroids decrease inflammation throughout the body. They're very, very useful, especially when you inhale them if there's a lot of inflammation in the lungs. So they're very useful for chronic asthma and for COPD. However, they are not for acute asthma attacks or acute bronchospasm. So you would not give a corticosteroid-based inhaler to someone who's actively having an asthma attack, actively having problems breathing. You can give it to them if they have chronic asthma, and it might be dosed once or twice a day for them, like usually 1 to 2 puffs once or twice a day. And that might be used along with a rescue inhaler for those occasions when they might need a bit more support. Now, the most important note with inhaled corticosteroids is to rinse after using these inhalers, because there's a fungal infection of the tongue or throat called thrush, which might happen if those corticosteroids and the residue from the inhaler itself builds up on the back of your throat, that becomes a breeding ground for the fungal species that creates thrush. It's easily treatable, but it's quite uncomfortable and not something that any chronic inhaler user would want to use, or would want to experience rather. Now, there's an increased risk for upper respiratory infections as well. And cough is the most common side effect, especially if it's not being administered properly. But our examples of corticosteroids, we have 3 of them, and these are probably the 3 that you're most likely to see: beclomethasone, or QVAR, budesonide, or Pulmicort Flexhaler, and fluticasone, or Flovent. We also have our short-acting and long-acting beta agonists. If you've ever had a rescue inhaler or an inhaler for exercise-induced asthma or what have you, you're probably very familiar with ProAir or Ventolin or albuterol in general. It is your typical bronchodilator that's used even in school-aged children, and it works by relaxing the smooth muscle in the respiratory system to improve that airflow. Now, it's a short-acting drug for acute breathing issues, but may also be used as a long-acting drug for chronic respiratory issues, depending on the type of inhaler that you're using. It might cause excitatory effects, potentially, nervousness, tremor, tachycardia or fast heart rate, and heart palpitations. So we like to use caution in patients with cardiovascular disorder or cardiovascular disease. However, I would say these are generally systemic effects. These are effects that occur throughout the entire body. It's important to know that they might cause excitatory side effects, but I think it's pretty unlikely that someone will get, at least when administering the inhaler properly, any sort of excitatory effect from taking the inhaler. Also, quite easy to remember because all of the generics end in the suffix OL, or all. So we have albuterol, or ProAir, Ventolin, and Proventil. Those are all different inhalers, the ProAir, the Ventolin, and Proventil. We have levalbuterol, or Xopenex, formoterol, or Foradil, and salmeterol, or Ceravent. So those are all of our short and long-acting beta agonists. I should also clarify that they're called beta agonists because they work on beta cells within the lungs to create that broncho relaxation, the relaxation of the bronchioles. The beta cells are in charge of sort of the expansion and contracting of the lungs. Now, we also have our anticholinergics. They work a bit differently. In some cases of asthma or COPD, you have a buildup of mucus. So anticholinergic inhalers work by drying out mucus while also relaxing and dilating the airways. So they're very useful in the treatment of COPD, in severe asthma where there's maybe a lot of mucus, and other high mucus chronic respiratory issues. Side effects of anticholinergics. Anticholinergic side effects include dry mouth or skin, constipation, urinary retention, and hyperthermia, or an increased temperature. They're very easy to remember though, because all generics end in the suffix tropium. So you have ipratropium, or Atrovent, and tiotropium, or Spiriva. You see Spiriva a lot, especially in COPD patients, and it has this really nifty way of administration. This inhaler, it's called a twist-haler, and you literally just twist it, and then it sort of puffs directly with this forced air stream from the capsule, and the person just breathes it in right there. The person breathes in that stream of air, holding it up to their mouth, and it's quite an effective way of administering the anticholinergic medication. So remember Spiriva and Atrovent. And then we have our combo inhalers. So a lot of times patients might benefit from combination therapy, where they have multiple drugs in one inhaler to improve breathing and ease the administration, so they don't have to keep track or even buy, or let's be honest, pay for multiple inhalers with the current healthcare climate. So they may include beta agonists, anticholinergic drugs, and or inhaled corticosteroids in a single inhaler, which can be very, very nice for a patient to consolidate all those inhalers into one. Now, they're most commonly used for chronic respiratory conditions, especially COPD, and the side effects are all as previously mentioned. So if you're taking one that's, for instance, a budesonide and formoterol, you're going to be taking one that is, as we recall, budesonide, an inhaled corticosteroid that can be combined with our beta agonist, our formoterol, to create Symbicort, budesonide and formoterol. There's also Combivent and Duonem, albuterol or ipratropium, and Advair, which is probably one of the most common. And it comes in this very, they call it the Advair discus rather, like a discus that you would throw in track and field. And that is a very, very commonly prescribed inhaler, especially for COPD patients. And that's fluticasone and salmeterol, otherwise known as Advair. So that is, and those combination inhalers, as I was saying, they would include the exact same symptoms, or rather the exact same side effects that you would expect with both of those drugs combined, with whatever category you were using. So beta agonist side effects would go along with anticholinergic side effects and whatever other combo inhaler you were using. Lastly, we have Montelukast or Singulair, and that's actually an oral medication for chronic asthma. So it's a tablet. It's usually taken at bedtime once daily, and it prevents attacks from occurring and prevents symptoms from worsening. So it's a leukotriene inhibitor or antagonist, meaning it's antagonizing your leukotrienes, which are just sort of inflammatory parts of your immune system or inflammatory messengers within the body that cause that airway inflammation. When you inhibit them or antagonize them, they can't work to cause that airway inflammation. So thereby you reduce the inflammation of the airway, especially in patients with chronic asthma or COPD. They're taken once daily, as I said, at night. Side effects might include dizziness, headache, abdominal pain, or increased risk of upper respiratory infection. I will include that they like to have dizziness and headache are probably the most common. So that's why you take it once daily, usually at night, because you're not going to be dizzy if you're falling asleep. So that just does it for all of our respiratory drugs. I know it was a bit of a long lecture, but if you have any questions, feel free. Thank you.